Very good morning to all present here. Thank you, Dr. Tarian and Dr. Judith, for this opportunity. Last month, I think in the first week of September, we were told to do an assessment for some of the patients. So I came with my students, and this is a small background what we have done here. So we did dietary assessment, that is a 24-hour recall we collected for 3 days, past 3 days, what are the food the patient consumed. So we have done a 24-hour recall for one child, and then one patient with bed sore, one diabetic patient, one patient with TBA and SCI. So what we came to know, the nutrient intake, mainly the protein is the one which these patients need more, but their protein consumption is very less. So what they try to eat is only the carbs, only the rice based foods. Like it's easy for them to prepare when they get food from home. No, they make one variety rice like puli sadam or lemon rice, or plain rice with sambar or something, and adequate vegetable is not there, fruit also not there. And some of the patient, they buy food from the small hotels which is around Bahayam. The two, they buy only variety rice. That's easy for them to buy, and cost also very less. So there was no good quality protein was there. Even most of the patients, out of 5-6 patients we have done, all the patients protein intake is less than 50%. When you see the carbs, the carb is more, and calories also they are not meeting the up to their requirement. So we have calculated the requirement for their specific disease condition, as well as we compare their intake for the past three days intake what they have consumed, which we came to know that is not even they are meeting the 50%. That is the result of that small assessment. And then we presented to ma'am. Then ma'am asked us to do one small presentation to us. So so that I'm here. So what is the learning point today? What are we going to learn? I hope this session is going to be really useful for you. We are going to see what is the nutritional care process and the impact of malnutrition in this outcome, and we are going to see what is the route to feed the nutrition, and how to calculate the protein and calories and other nutrients, and what is the enteral formulas. So when you say enteral formulas for NG feeds, we have both exclusively commercial formulas and then home based formulas. So in our dietary department, we are not exclusively making the commercial formula feeds. So it's like a kitchen based, home based formulas, partially, like we use all the ingredients what is available at home, as well as we do add some of the simple protein powders. So without that we can't make it. So when you see many hospitals in India, so they go only for the commercial formulas. So they just open the packet, put water, shake it and feed the patient. That's what they advise to them also. So many of my friends are there in Chennai, so they won't go for kitchen based. So only in CMC we are very pocket friendly, patients pocket friendly, so that we go for the commercial, little commercial, mostly the home based formulas. That's why I am just going to tell you what are we doing, and then how to address whatever symptoms when you feed the patient, when you enterally feed the patients. So now I'm coming to a small introduction. So malnutrition is more prevalent among the hospitalized patients throughout the world. And what is the nutrition or the dietitian's role? So the nutrition's role in the hospitalized patient is to formulate the most appropriate nutrition therapy for each patient based on their nutritional status. Patient may be overweight or patient may be underweight. So there is a various nutritional intervention strategies to choose, where you can go for a natural food or you can go for natural supplements, enteral feedings, maybe partially, or even a parental nutrition if it is needed, which has to be decided by the doctors. This macro and micronutrients are involved in the cellular, structural and immune process in all phases. Macronutrients, you all know that energy, protein, fat and carbs, whereas the micronutrients are vitamins and minerals. So what is malnutrition? You all know that, I'm not going to say. It's either overweight or underweight. Both are considered as a malnutrition. Both has got an impact in the nutritional status. So now coming to the malnutrition, when the patient is malnourished, so there is a more chance for the morbidity, wound healing will be delayed, and more chances for the infection, other complication, and mortality is more. So that it indirectly increases the length of the hospital stay, and cost of the treatment is more for the patient. So overall quality of the patient is affected. So hence here the nutrition plays a very important role to prevent or to correct the malnutrition, whether it's overweight or underweight. So when the nutrition is compromised, what is going to happen? So there will be a weight loss, there will be very low BMI, may increase the weight, vitamin and mineral deficiencies, micronutrient deficiencies will be there, dehydration, poor glycemic control if the patient is diabetic, and if the food intake is very less, so there is evidence for suboptimal intake, which results there is a subcutaneous fat loss also will be there, and muscle wastage will be there if you are not giving a correct nutrition. So what is this NCP? NCP is a nutrition care process. Here the dietitian's role starts. So there are 4 components in that. One is the assessment. So this is what we are doing for our patients. One is the assessment, that is a dietary assessment. The second one is the diagnosis. Diagnosis is a nutrition diagnosis, not a medical diagnosis. Intervention and monitoring. So what are we doing here in the assessment? So as soon as we meet the patients, we collect all the demographic details, and then we'll see what is the medical history, surgical history, what is the diagnosis, and is there any medications which interact with the nutrients. Like if the patient is on warfarin, we have to go for the, for example, I'm telling low vitamin K diet. So nutrition assessment, what are we doing here? There are 4 components. One is the anthropometric assessment, which is very important. This is called ABCD analysis. Anthropometric assessment, we check the height, weight, BMI, desirable body weight, and then find out whether patient is underweight or overweight. Based on that only the energy requirement will be found out. So that as anthropometric assessment is very important. And coming to biochemical values, we look for albumin. If the albumin is very low, they have to take a very high protein diet. If not, also all TBI, SCI patients need to take a high protein diet. And then we look for ACPC, HbA1c. These are the biochemical values which is relevant to the dietitians. And then we look for the liver function test. Is there any albumin is low or bilirubin is high? Or kidney functions we look. Is there creatinine is high or potassium is high, urea high? If it is high, we always coordinate with the doctors, communicate with the treating doctors, and then we check and then give. Sometimes they might miss out. Say for example, patient might be on normal diet, creatinine may be slightly high, so we just communicate with the doctors if creatinine is high, whether the patient is having any renal involvement. Do they need a renal protein restricted, potassium restricted diet? Or if the uric acid is high, do they need a low purine diet? So we always communicate with the doctor. So these are the things we are having a nutrition assessment screening, we are having a nutrition assessment. As soon as the patient takes a hospital diet, we go and visit the patients within 24 hours. So we do the nutritional assessment. So in the nutritional assessment, we have all this 4 components. So we do anthropometric assessment, we check biochemical values, and clinically we just ask the patient whether they can able to take their food, is there any edema, is there, their bowel movement is alright, other simple things we'll ask. And coming to the dietary here, it plays a very important role. Dietitians, we cannot simply ask the patient to, so whatever we write in the paper, so the dietary suggestions or dietary intervention should be highly individualized. It is a tailor-made diet plan we are doing for each patient. It's not a common diet for all. So individually we assess, and then we ask their economical status also we'll find out. So I could say most of the patients who come from rural, they can't even afford to buy 100 ml of milk. So I can't simply tell them to buy 500 ml of milk, or go for egg in a day, or go for non-veg. So it's going to be useless. They are not going to follow it. So find out their economical status, their affordability, their likes, dislikes, their family eating pattern. So these are the important things. We quickly assess them and we'll ask. For example, I am telling, the patient can't afford milk, or if the patient don't like milk, the milk is the good source of calcium. So what could be the other alternate for the milk? So ragi is the other alternate for the milk. So ragi is the richest source of proteins and low in cost. So we should find out the other alternate. If the patient is not tolerating milk, but the patient likes milk, wants to take milk, can afford to take milk, then what is the other alternate? Other alternate can be the paneer or can be curd. So, and dal we can substitute, or soya flour we can substitute, or soya paneer, tofus, if they afford. So these are the dietitian's role to find out quickly before we suggest or before we plan the diet. And as I said, anthropometric assessment is very important. In anthropometric assessment, finding out the height, weight is very important. Why? With the height, weight only, we are going to calculate the nutrient requirement, how much calorie and how much protein do they need. So for most of the patients, this TBI, SCA patient, they cannot stand. When patient cannot stand, how do you measure the height? So we used to see in the ward, they write can't stand, but we dietitians, we can't just leave it like that. Can't stand means there is no use. So this is the other way of finding the height of the patient. So you can stretch the arm, both the arm, and from this finger, middle finger tip to the other hand, middle finger tip, you can measure with the inch tape. So this is the indirect method of measuring the height of the patient when patient cannot stand. Okay, you will get the height. Even you can measure and see on your own also. Maybe 1.5 centimeter only difference will come. Otherwise, you will get the exact height. And if the patient cannot stretch their hands, so this is the other method of finding the height. This is the demi-span. So you can get the values, and for female and male, this is the formula which is given down. I will leave the PPTs, you can check it later. And if even the patient cannot stretch their hands, you can measure the knee height, and this is the formula which is given female and male. When you apply it, you will get the height of the patient. So now you know the height of the patient. Even if they can't stand, you know height of the patient. Now I got the height. So weight. How am I going to find out the weight? Maybe you can ask the relatives, or if they know the usual weight, maybe you can note it down. Or how do you find out, ma'am, if they cannot stand the weight? If they cannot stand, is there any way to find out the weight? Okay. So if you know the weight, so I have given you a simple formula here. Height, that is 155 centimeter, weight is 50 kg. So to find out the desirable body weight, all the nutrient calculation is based upon the desirable body weight, DBW. So a height in meter square into 20 BMI, height in meter square into 22 BMI. What is this 20 and 22? 20 and 22 is the normal BMI. Normal BMI for Asian is 18.5 to 22.9. It's a very big range. So we are not going for a very big range. We are taking the middle value, that is 20 to 22. 20 to 22. If for a person who is 155 centimeter wants to fit in the normal BMI of 20 to 22, what could be the desirable body weight? This is the calculations. So height in meter square into 20 BMI, height in meter square into 22 BMI. So if I am a 155 centimeter, my weight, my desirable weight should be 48 to 52. So now I am 50, I am almost normal. So you got the desirable body weight. And this is the adjustment of desirable body weight for patient with disability. Patient with paraplegia, you have to subtract 5 to 10% from the desirable body weight. So here the desirable body weight is 48 to 52. Let me take 52 is the desirable body weight. From 52, I have to reduce 5 to 10% for paraplegia. For quadriplegia, I have to reduce 10 to 15%. So I can't expect the full desirable body weight when patient is having the disabilities. When patient is amputated, this is a formula to calculate. That is, the estimated desirable body weight is equal to 100 minus percentage of amputation divided by 100 into desirable body weight. So you know the desirable body weight 52 kg, and apply all this percentage according to the patient's amputations. So if it is trunk, it is without extremities, entire leg, below knee, foot, entire arm, forearm, hands, all the percentage is given. So this will give you the desirable body weight for the patient with amputation. So now now you know the desirable body weight. So with the help of desirable body weight, we are going to find out the energy and protein requirement. Before that, I just wanted to share you, this is something called a Harris-Benedict equation. I hope most of you would have studied in your books. Most of the books have this formula. So, total energy expenditure, that is the totally how much energy you need for the day. So how to calculate the total energy expenditure? BE, basal energy expenditure, into activity factor into injury factor. Activity factor is nothing but whether the patient is confined to bed or normal activity, into injury factor. Injury factor is depends upon the patient's condition. So to calculate the basal energy expenditure, formula is given for male and female. You have to apply weight, height and age. So you get a value. Into that you have to multiply the activity factor and injury factor. What is this activity factor? It's given there. Confined to bed and then out of bed. Injury factor is given like surgery if it is a minor, infection it's a mild, moderate or severe. For maintenance is only 1. Whereas for the surgery, again you have major surgery. Trauma, here comes your patients. All the trauma, skeletal traumas is 1.3. So now what you have to do? You are finding out the basal energy expenditure and you are going to multiply it with confined to bed or out of bed, and then you are going to take a trauma, skeletal patients. For you are going to take this 1.3. So now you got one answer, one number. That is the energy requirement for the patient. So now, so nutrition consideration in TBI due to increased metabolism. So this TBI patients will have an increased metabolism. So which is around 120 to 250% of basal energy expenditure is increased. Even a sedative paralytic can alter the metabolism by 76 to 120% of estimated BE. So most of the TBI patient needs 140% of BE. Can you imagine? When you calculate this value, basal energy expenditure, you have to give 140% of basal energy expenditure, you have to take it. And more calories may be needed even if there is additional injuries, stress and bone fracture and sepsis. So now coming to the protein, so most of these patients will have a protein breakdown. There will be excess protein breakdown. So protein catabolism appears to be peak in 8 to 14 days after injury. So recommendation of protein is definitely high, 1.5 to 2 gram, whereas a normal protein requirement for us is 0.8 as per the recent recommended dietary allowance which is given by ICMR 2020. It's only 0.8, whereas these patients needs 2. Even if they are having a severe bed sore, we can go up to 2.5 also. So much protein they needed. And most of these TBI patients will tolerate intact protein. Intact protein is nothing but protein as such what we get from the food. So as per the ASPEN and ADA evidence-based guidelines, they recommend if the patient is on tube feed has to be started within 24 to 48 hours of the admission. And the European Society for Parental and Enteral Nutrition also supports enteral nutrition has to be started within 24 hours if the patient is hemodynamically stable and have the normal functional GI tract. And intragastric feeding, tube feeding has to be started within 72 hours after injury, which is recommended by the American Society of Neuroscience Nurses to improve the feeding tolerance and outcomes. Not only that, the Brain Trauma Foundation also gives some guidelines. They emphasize that enteral feeding has to be started within first week of the post-surgery to improve the outcomes. And by the end of the first week of hospitalization, the patient has to reach at least 50 to 65% of the requirement. So if the requirement is 3000, then they have to reach by the end of the week at least 1500 calories they have to eat. So we have to slowly start and step up. So now these all are very big numbers, you know, BE, injury factor, activity factor, it's all are very big numbers. We don't have time to sit and calculate all these things. That is an indirect method which is given by ASWAN guidelines. Very quick, short nutrient prescription. So, calories should be 35 to 40 kilocalories per kg desirable body weight. So, I have already taught how to calculate the desirable body weight. So, we have calculated one desirable body weight which is 52 kgs. Okay. So, now the calorie requirement is 40 kilocalories. So, 40 into 52. Initially, start slowly. So, we can't right from the day one, we can't go start with 40 kilocalories. Just start with 25, wait for 2 days, see the tolerance, and then gradually step up. These all the dietitian has to observe the tolerance. Then go for 30 kilocalories, 35, then reach 40 kilocalories, and protein 1.5 to 2 gram per kg body weight, and fluid is 1 ml per calorie. If you are giving a 2000 calorie, you give 2000 ml. The 2 feed patients. For the normal patients, it's up to the thirst they can take. And especially a nutritional prescription for trauma patients, here almost I'm repeating the same thing. Only I just wanted to say, if the patient is obese, then we have to restrict the calories. So if patient BMI is more than 30, then we have to stick on to 25 kilocalories per kg desirable body weight. And protein, of course, we have to give them a high protein diet for even an obese patient. Now coming to the diet part, always a balanced diet, that is the key for good health. So what is balanced diet? I have kept one thali here. So I will just give you an example. Today my lunch is one tamarind rice with potato curries. I am eating that. And sir is eating this thali meals. So what is there in the thali? All 5 food groups are there. Rice, cereals, sambar, that is dal, one fish curry, non-veg is there, 2 vegetables are there, and then curd is there. So all 5 food groups, cereals, pulses, vegetables, fruits, milk products, non-veg, and some amount of oil for cooking the food. So my diet is balanced, or his diet is balanced? So his diet is balanced. So each meal we try to eat a balanced diet, so you get all the nutrients. So you can ask, ma'am, we all are working, and most of the people are very busy with their work schedules. Do we have time to cook every day with all these thali meals? Yes, we can. But this thali meal I have just given as an example. But my concept is to give all 5 food every day. Like, you should innovatively think your cooking method. Simple, just tips I am telling you. No need to cook 2 separate curries. Make 2 vegetables and add one dal into that, make one puttu. So add 200 grams of vegetables, 2 different vegetables, put it in one dal. So one dish. So if you are making a chapati, grind the green leafy vegetable, add into the chapatis, or add some mashed vegetable into that, add little bit of oil, make the chapati. So no need to cook separate vegetable as such. So one chapati, that's so colorful, more nutrient, easy to prepare. So my concept is all 5 food groups should be there. So in the right side you have a healthy eating plate. So you can have a 9-inch quarter plate. So this plate is divided into half. One half. The one half should be full of fruits and vegetables. The rest one half is divided into the quarter. Okay, so 1/4 should be your proteins. It can be a non-veg, it can be a fish or chicken or whole grams, legumes or dal or nuts. Okay, and the rest quarter should be your rice or ragi or a wheat or the carbs generally, or small millets, whatever it is. Do we all eating like that? We eat ulta. Not we, commonly I am telling. When you see the carbohydrate consumption of our Indians, it's more than 80%. Whereas all the guidelines says eat only 60% or less than 60, 50. So when you see Western people, their carbs intake is only 40%. So what the Western people eat, they'll eat one big chicken and then they'll take lot of salads and they'll take one slice of bread. Whereas we Indians will take more rice and few vegetables in the sambar, where it will be floating in the sambar, that's it. So when we used to go for community orientation programs, and we ask the people what they cook, we measure their food, and there is other weighment method. So we'll measure and then we'll ask them to cook and show. So if you see, they'll make one sambar in the morning, they'll keep it for 3 meals. They'll make one sabjis, hardly they'll make one sabjis. So mostly they'll eat more rice. If you see, the quantity of carbs is more, the quantities of rice or ragi or whatever the small millets is more, whereas the dal, the protein part is very less and vegetable is very less. For the entire family itself, they'll buy only quarter kgs. Still many families are buying only quarter kgs of vegetable and they'll share it. So here the protein rich foods, all non-veggies, white meats like fish, chicken, egg, milk product, all whole grams and legumes. So when I talk to the patient, when I ask them to take dal or whole gram or sundal, they'll ask, the common question they'll ask is, madam, that white color sundal, no, that green color sundal, no. So people knows only the white color and green color sundal. Sundal is the whole grams and legumes. So I used to say them, there are 40 varieties of whole grams and legumes are available in the markets. And there are some whole grams and legumes which is very low in cost also. Like a green gram, horse gram and all low in cost. Brown chanas and all low in cost. So people are not aware, they know only 2 colors. So here the dietitians are there to educate them. And now coming to the diet part, like dysphagia is very common in TBI patients. So that's swallowing difficulties will have. Maybe initially we can start with the liquid diets. Even liquid diets can be a thick liquids. There are few tips like how we can enrich the liquid diet itself. Say for example, what all comes in the liquid diet? It can be a porridge like ragi porridge, rice flour porridge, fine broken wheat, or even a powdered oats. We can cook it in the milk. We can give them a milk or ice creams or custards, thick curds, yogurts, well strained soups. It can be even a dal soup or chicken soup, a vegetable soup, green leafy vegetable soup, palak soups we can give. And thick fruit juices, hot Coca-Colas we can give, colas we can give, and avoid raw eggs. Why raw egg has to be avoided? Still people are giving just, when I was a student in 97, I used to see in N1 wards often egg flip. They'll give raw egg just to mix it with plain milk and they will feed the enteral tube patients. Then after that it's banned by Mrs. Mahmud. So she strictly told that egg flip should not be given. The reason is, one is the contamination. The raw egg they will break and give, it may be dirty the shell, maybe chance for contamination. Second one is the biotin absorption is affected because of avidin which is present in the milk, that is the protein which inhibits the absorption of biotin. So egg white, raw egg white is banned. So egg flip is banned, should not be given. And how to enrich this liquid diet? Yes, I am taking a liquid diet. I am taking a porridge. Porridge, how do we prepare? We prepare only rice flour or ragi flour cooked in the water and we simply add some sugar and take it. So now my idea is to educate the patient to enrich that small quantities of porridge. How am I going to enrich? So you can add some dal powder into that. You can add some nuts powder into that. Instead of cooking the porridge, that rice flour or ragi, whatever it in the water, you can ask them to cook it in the milk, so that it becomes more nutrient dense, and you can add some roasted groundnut powder or almonds powder or gingerly seeds, this ellu, that powder you can roast it, which is rich in omega-3, that powder can be added. Or a protein powder, the name called Nuzovin, which is available. The cost also very less. It is the highest protein, just a 1 scoop gives 9 grams of protein, which is equivalent to 50 grams of chicken or 50 grams of fish. Just 1 scoop, you can ask them to add it in the porridge. So if you take a plain porridge which is cooked in the water, your calorie content of the porridge is only 85 and the protein is only 1.5 gram protein. So by giving the tips and when you encourage the patient to add any one of this, your protein contents become more. So you just add 1 scoop of a protein powder or nuts powder or dal powder, even a skimmed milk powder, your porridge protein content becomes 10. Where is 1.5 gram, where is 10 gram. So if you take even a 200 ml, 10 grams of protein you will get it. And this Nuzovin protein powder, we are not here to recommend any of the protein powder unless it's needed. Say for example, patient is having severe bed sore. So they have to take a high protein diet. These are some of the protein powders they can go for. So one advantage of this Nuzovin protein powder is they can add it in the even idli or dosha batters they can mix. Even cooked vegetables they can mix. It's very bland in taste, you can't make out. So if you add just 1 scoop in 2 idlis batter, obviously your protein content of idli becomes more. Ordinary idli gives you only 2 gram proteins, whereas when you add this Nuzovin powder, 10 grams of protein you will get. This is one advantage is when patient is having difficulty in eating more quantities of food. Patient cannot eat more than 1 idli at a time. Okay, you give 1 idli, but the nutrient content is more. That's my idea. That's it's not going to be for lifelong. Till they get recovery, we are going to advise. And even for the porridges, like you can add 1 teaspoon of oil in the porridges or some milk powders also you can add, so that the calorie content is increased. And same way the chapatis, instead of making chapatis or dosha with plain batter, rice flour batter or wheat flour, mix some soya flour or mix some dal flour into that, add some oil, add some milk into that. Instead of water you can add milk and make a dough. So ordinary chapati gives only 3 grams of protein. So when you enrich the chapatis with all these things, your calorie content also increase and the proteins becomes 7 or 8 grams of protein in 1 chapatis. So these are the small tips we can advise the patients to follow. And coming to the bland diet, so once the patient is able to take a bland diet, what is bland diet? It should be well cooked, soft. It should not have much of fiber, should not have spices, no masalas, it should not be highly seasoned foods. It's a well cooked double boiled foods. Like what all we can suggest? We can suggest a double boiled rice and dal khichdi, pongal, and then mashed vegetables, mashed potatoes. You can add some milk, 50 ml of milk into potato, mash it, add some butter or ghee or oil into that. Even no need to buy butter and ghee, also add 1 spoon of oil into that, so the calorie content increases. Potato also high in calories, they need more calories. And coffee, tea should be avoided. Carbonated aerated drinks, cool drinks should be avoided. Not much of salted food should be there in the bland diet. So they can have custards, puddings, milkshakes, dal soups, green leafy vegetable soups, palak soups. So these all you can suggest in the bland diet. So again few tips, that is, even you can add fresh grated paneer or curd, you can just add it on the idli or dosha. So paneer again good quality protein, rich in proteins. Paneer you no need to buy from outside, you can buy the milk which is low in cost and make a paneer at home, so that it's quite reasonably cost is less compared to buying paneer from outside. And then 2 teaspoons of milk powders may be added in the milk or in the curd. When you set the curd, then the protein content of the curd and milk also becomes more. And you can add curd while making chapatis or doshas. If you make, you can add a curd instead of water, you can add a curd. The quality of protein also becomes better. And as I said, almond powder, peanut, sesame powder, these all you can add it in different way. These all innovative thinking is needed. Like we need to educate the relatives, that's it. So what are the sources of the proteins and how you have to incorporate in the food, how to enrich the food. These are the small tips they need. Again, we are not here to recommend any of the protein powders. If the patient is well to do, affordable to buy, so they can go for some protein supplements like Kabipro or Nuzovin or high protein resource. And these are some of the formulas what we are preparing in our dietary department, which is really going to helpful for the patient. So this is isotonic formulas where 300 ml and then 300 calorie, which is easily tolerated by the patient. So we take our rice flour 5 teaspoon, that is 25 gram, and we take Complan 30 grams, milk 75 ml, oil. Just cook the rice flour in the water, add milk, add Complan, put off the fire and then add Complan and oil into that. There is no sugar. If you want, can add a sugar if patient is not diabetic. So this just gives you 300 calories and 9 grams of protein. So this blenderized formula can be given for an enteral feed, that is for the tube feed patient, as well as the patient who is taking oral diet also. Say if the patient is sick, not able to take the entire meal, not able to take more quantities of food. So in between by 10 o'clock or evening 3 o'clock or the bedtime, these formula feeds can be given. This is something called ONS, oral nutrition solution. So if you give 3 times of this, 900 calories they will get. If the requirement is only 2000, then 50% of your calories the patient can easily meet by taking this. This 300 ml need not to be taken at a time, they can split and take also, like 100 ml at a time or 50 ml at a time. And one more variation, if the patient can't afford to buy Complan, they can add some nut powder or dal powder into that. Even a blenderized chicken or fish, after boiling the chicken, 50 grams of chicken, boil it, nicely mash it, add it into that feed. These are the variations you can make instead of Complan. Nuts powder, dal powder, almond powders or groundnut powders, or fish or chicken. So these all are not, I am simply telling, these all we have tried in our dietary department. We have a subject dietetics. I am handling dietetics for my MSc students as well as PG diplomas. So we have tried exclusively home-based formulas, no commercial formulas. Feeds we have tried. So the consistency also good, taste also good. We have given for evaluation for all our staffs. They said the taste is good, really good. So the composition is very important. The ingredients, how much quantity, you should use the right quantities. So we tried some 7-8 varieties of exclusively home-based formula feeds we have tried in our food science laboratory. And this is a very ancient formula right from Mrs. Maman period. Our ma'am only taught this high calorie cereal milk. Even if you go to pediatric wards, the nurses used to teach the mothers for the children, this is a formula, high calorie cereal milk. Even this has been taken as a reference for by many hospitals in India. Many of our dietary departments from other hospitals are following this high calorie cereal milk, which is very, very simple, easily available ingredients. You know, only a rice flour, which is available in everybody's house. Instead of rice flour, you can use ragi flour also. Milk 250 ml, sugar 20 grams, sunflower oil 10 gram, coconut oil 10 gram. Just mix the rice flour in cold water, take some 100 ml of water and 250 ml of milk, boil it, add this rice flour paste, cook it for only 2 minutes. If you cook it for a long time, it becomes very thick. It will block the tube if the patient is on enteral feed. Or if the patient is taking orally, it's fine. Cook it for only 2 minutes, put off the stove and then add sugar, oil into that. If the patient is taking orally, maybe you can add some cardamom powder also to increase the flavor. It gives a nice flavor, and it's very smooth consistency. For the tube feed patients, it will flow nicely into the tube. You cannot block it. So imagine you will get a 500 calories. It's near about 500, 475. Even you can add little more of sugar or oil into that. Make it 500 calories, doesn't matter, and gives a 10 grams of protein. So if you eat one big thali of lunch, you will get this calories. If patient is not able to take so much of food at a time, this can be the substitute, even for the children and even for the adult also. And this is the high protein formula feeds we are preparing in our dietary department, which gives a 30 grams of protein. The volume is only 200 ml. Ma'am, you won't believe this formula name called PMR blend milk. We kept the name PMR. It's right from Mrs. Maman's period. This is, I would say, some magical formula. With my experience, most of the patients from Q3, M2, A2 ward patients with bedsore. severe bed sore. The moment we see the patient, we ask, do you have bed sore? All the A2 patients, Q2 and all, Q2, Q3, we ask, do you have patient is having bed sore? If bed sore is there, we'll recommend this formula. We'll send from our dietary department this composition. You won't believe, within 1 or 2 weeks, the bed sore is reduced. It will take care. This contains a good quality protein, 30 grams, high biological value protein, and calorie also 554. And it's very easy to drink, 200 ml. So we'll tell the patient to drink 50 ml at a time. It's very easy to drink 50 ml at a time. Keep it in the fridge and take it small, 50 ml at a time. So this contains exclusively sagar, that is a skimmed milk powder, milk, and then high protein resource oil. That's it. And taste also very good. It's not only for the enteral feed, even for oral also we can have it. It's all like a substitute along with soft solid or liquid diet. Patient is on liquid diet. Through liquid diet, you can't meet up the calories. So this can be the substitute. Either this or this or this. You can choose it as per the need of the patient. So when patient is on tube feed, if the patient is having diarrhea, how to manage it from a dietary point of view. So check for if the patient is having any antibiotic first, and then check whether the patient is having any lactose intolerance. So if your enteral feed formula is mainly based on milk, then patient might have the lactose intolerance. Patient may not tolerate it. Then make your formula as lactose free. So instead of milk, we can add a curd in the feeds, or you can find some other substitutes, and then find out whether the patient is having any nutrient malabsorption. Then you have to go for semi-elemental diet, which is exclusively available as peptamen, which is semi-elemental pre-digested formula. So it does not require much digestion. So all the amino acids, proteins are in the simpler form, that's amino acids, and it's very easy to digest. So those formulas we can suggest. And if there is any bacterial overgrowth, then you check for the stool test, and check for the infusion rate. If the patient is on continuous feed, then check for the infusion rate, then reduce it, adjust accordingly. And then hyperosmolar formulas, we have to check whether the formula is hyperosmolar, meaning normal formula, isotonic formula means 1 ml should give you 1 kilocalories. That is this standard formulas. 300 ml, 300 calories. So the patient will well tolerate. Hyperosmolar is this, 250 ml, whereas nearly 500 calories. That is 2 calories per ml. So if your volume is less, calorie is more, the patient may not tolerate. This you really need to look. So this may be suggested for a oral feeds, whereas when it's come to enteral, you can go for the standard formulas. Okay, so check for that. So we used to check, and then we change the formulas. Sorry. And if the albumin is very low, it may cause diarrhea. Maybe we can give to protein rich feeds. Almost all of your patients will get a protein rich food only. And if there is a constipation when patient is on tube feed, then he has to increase the fluids with discussion with the doctor. After discussion with the doctor, we cannot do on our own. And then maybe the stool softeners or lactase can be recommended as per doctor's advice. And from our dietary side, what can we help when the patient is having a constipation? Can give a palak soup. With my experience, I have seen many patients who is on tube feed, who is having constipation. We give palak, boil the palak. Mainly this palak has got some wonder. Mash it, and even palak is very smooth paste when you mash it, and then make a soup. Just filter it and then feed the patient. And we can use a ragi flour instead of rice flour for making the tube feed formulas. So when you use the standard formulas rice flour, you can use a ragi flour. Ragi is again rich in soluble fibers, which really helps. These are the positive comments and feedbacks I got from the patients personally. So, and then if there is any electrolyte abnormalities which has to be corrected as per doctor's guidelines, and check for the other drugs like narcotic and morphine drugs. And then if there is an intestinal dysmotility, then can increase the soluble fiber and can increase the fluid with doctor's advice. And the patient is having nausea and vomiting, again check for the infusion rate, correct it. The drugs will be useful, and then formula also to be checked, the osmolality of the formula as I said. If the formula is hyperosmolality, then we have to change the formula accordingly.